Welcome everyone. Thanks for coming. I'm Robin Pommy, for anyone who doesn't know me, one of the CNEs on Unit 57. So I want to welcome you to our third BMT Heme lecture in this series. We're happy to be here, at least virtually, with all of you. And I want to take a moment to thank the Leukemia and Lymphoma Society for supporting our lecture series yet again. We've worked with them for over a decade. They've provided meals for us and a platform to run this lecture series. So prior to announcing our keynote speaker, I want to welcome Desiree Naylor again, who has been our go-to connection with the Leukemia and Lymphoma Society. She is definitely passionate about providing opportunities for us, that being us healthcare providers, along with advocating for our patients. So I'd like to pass it on to her to speak a bit about the society.
Perfect. Thank you so much, Robin. Hello, everyone. Again, I don't want to take up too much time because I really want to get to the presentation. I'm really looking forward to this one. But like mentioned, my name is Desiree, and I'm the Community Services Manager for the Leukemia and Lymphoma Society. And it's my pleasure being here tonight for the third virtual session. Tonight, I really wanted to highlight one of my favorite programs, and that is our First Connection program. With this program here, it is a peer-to-peer program that matches newly diagnosed patients and their families with trained volunteers who've been touched firsthand by a blood cancer and shared similar experiences. Our trained volunteer survivors offer caring support and information by sharing their special perspectives on their recovery process. And trained caregivers share their story and advice on how to support a loved one going through a blood cancer diagnosis. The First Connection participants and volunteers are matched by age, diagnosis, and gender when possible. And anyone with a blood cancer is eligible to receive a call. I kind of wanted to show, normally we would love to bring in an individual to talk about their experience as a volunteer. Unfortunately, this year is a little bit different. So I wanted to put a quote up there of just a call that we had recently where the patient said, you know, I didn't know what to expect. I didn't even know what I really wanted to get out of the conversation. You exceeded well beyond my expectations, and for that, I am grateful. And this year is the individual talking about the volunteer that they were able to have a conversation with. We are relaunching this program in the next little bit. We really want to branch out and offer the phone calls to individuals that are on the younger demographic, our young adults, as well as making it more accessible for our caregivers. So if you know of anyone that would benefit from this program, the referral process is really easy. Just connect with me or send them our way, and we set up everything for them. And if you have any questions about any of our programs and services, please don't hesitate to reach out. So again, thank you so much for having us here tonight. I'm going to pass it over to Robin to help introduce tonight's key speaker.
Thanks again, Desiree. So now I feel fortunate to introduce our keynote speaker, Dr. Kareem Jamani. Dr. Jamani has been one of our attending hematologists and clinical assistant professor for the University of Calgary since 2017. He completed his fellowship in Calgary and Seattle, and I learned that most recently he completed his master's in public health through Harvard. So Dr. Jamani also is the clinic director for the Alberta Blood and Marrow Transplant Long-Term Follow-Up Clinic. He's well known by most of the staff who are attending this webinar and is highly respected by all of us. It is always a pleasure to work with him, and I'm very excited to have him present tonight. And I can see that many are as excited as I am because this is a very well attended webinar. So without further ado, I would like to pass it on to Dr. Jamani.
Thanks, Robin. I'm going to share my screen. And here we go. Okay, so you guys can see my screen, right? Okay, so I'm on like full-on Zoom background noise blocking, so hopefully you won't hear dogs or kids or piano or anything else that's going on here. So thank you so much for having me. Thank you for introducing me, Robin. And it's always a pleasure to talk in front of you guys. So I'm going to spend time reviewing aspects of survivorship after transplant, the type of transplant that we do. And I'm gonna admit that I have a little bit of a bent towards allo transplant in terms of talking about survivorship, but really what I'm presenting does apply really for the most part to both auto and allo transplant. And I'll tell you about some of the work we're doing in our LTFU, including some of the research projects that we're working on that will help us kind of have our own local data when we counsel our patients and come up with our guidelines. So I want to describe some of the risks of late complications after transplant. Obviously, going through all of them is probably 5 different lectures, but I want to highlight a couple of areas and then describe some of the local efforts that we've been working on over the last about 3 years, I'd say 2.5 years. And I don't want to keep it too long because I know everyone's tired of sitting on Zoom for long periods of time, but hopefully have a lot of time for, if I keep track of time, hopefully have a lot of time for the question and answer. So I don't know if anyone's read this book, but if you haven't, it's fantastic. So it's the memoir of a young gentleman who had an allo transplant for acute myeloid leukemia. And after transplant, he develops chronic graft versus host disease, fairly severe, and a number of late toxicities, most significantly osteonecrosis of several of his joints. And in the epilogue of his book, he talks about this. He talks about how there's no happily ever after ending, at least for him, that it's not kind of tied up in a nice, neat bow. And so this is his quote. He says, "The prevailing misconception says that with diagnosis, there's only one of 2 outcomes, death or full recovery. Most people want that neat ending, but most of the time, the nice, neat bow is nowhere to be found. Instead, they're left with an untidy ending, somewhere in the darkest shadows of the gray area. Just because someone survives does not mean they get to truly live." So this is really the thesis of his book, and for him, I think what he's pointing out is that many, not all, patients continue to struggle with physical symptoms and psychosocial problems long after their transplant. For him, it was really this osteonecrosis of his joints from a physical perspective, and from a psychosocial perspective, the loss of connection to his peer group, derailed school and career plans. And so I think it highlights, that at some point post-transplant, we need to move on from the early toxicities, the graft versus host disease, the infections that happen early on, and we need to think about what other toxicities, specifically what other late toxicities might be on the horizon for patients, and how we can modify the risk of these. And so this is mainly what I want to focus on. So I'll start with the good news. We know that survival after stem cell transplant is improving. This is a paper that was published from the Seattle group where they've been doing transplants since the 70s. And they looked at 2 different time periods, 93 to 97 and 2003 to 2007. And they found that the probability of patients surviving transplant was significantly higher in the more recent group. It doesn't look like a huge difference, but those curves are fairly separate. It's about a 10% increase in probability of surviving in this newest time frame. And it looks like it's time to add another curve, probably the 2008 to 2019 curve. And that curve, I'm guessing, would be even higher in terms of probability of surviving. So the challenge is that we need to continue to monitor patients carefully, even when they've done very well early post-transplant. So here is a survival curve of over 500 patients transplanted in our program in Alberta, dating back to 1999. And I've selected out really the best patients here. These are the patients who survived until 2 years without relapse of their underlying cancer. And what you can see here is that the estimated survival out at kind of 10 to 12 years here it's about 88%, if I can put that in numbers for you. And so that's quite good, but it also means that we're losing about 1 in 8 of our patients in the decade after transplant. And because the average age of patients that we transplant is 50, I would suggest to you that these patients are dying earlier and in greater numbers than their age-matched peers in the general population. And so this is exactly what the bone marrow transplant survivor study did. This is seminal work done in the US. This is looking at 1,500 two-year survivors of transplant and comparing their survival to that of the US general population. So the top curves here are US general population matched for age, and the bottom curves here are the allo transplant recipients. And so really what you can see here is that there is a huge difference in terms of survival when compared to the general population. And to put this risk of death kind of numerically, we can calculate what's called a standardized mortality ratio, which is simply the ratio of observed to expected deaths. Observed to expected deaths in these patients. And so you can see here that even out at 20 years post-transplant, there are 3 times more observed deaths as compared to expected deaths. So these patients continue to have an increased risk of death even when they're out at 20 years post-transplant. One might think that it's the patients that get chronic graft versus host disease who are at risk for late death, but that's actually not the only explanation. So we know that patients who had chronic graft versus host disease do have a higher standardized mortality ratio. They have a 12 times higher risk of death versus the general population. But even those who did not get chronic graft versus host disease, there is still about a 7-fold increased risk of death. So that's still fairly significant for patients who are doing very well after transplant without graft versus host disease. So what are the causes of late mortality? And of course, we still deal with relapse. So unfortunately, even though patients make it to 2 years post-transplant, some of them will still relapse, and that does make up a part of this, the causes of late mortality. And graft versus host disease accounts for another chunk there, but that's about half. So there's this other half of the pie on this left side here. And you can see here, these are things that we need to think about. So these are what we call subsequent malignancies, pulmonary disease, cardiac disease, other treatment-related mortality. There is a problem getting data sometimes for patients who are far post-transplant, so sometimes the cause is undetermined, and late infections are also a problem. So the other way we can kind of quantify this is looking at morbidity. And so we can look at patients' physical health conditions late after transplant. And this is also from the bone marrow transplant survivor study, some of the data I showed you a couple slides ago. And this is now a follow-up study of 10-year survivors of transplants. And what they did here is they compared the stem cell transplant survivors on the left side here to their siblings. And they found that almost 3/4 of patients who had a stem cell transplant had at least one chronic health condition, as compared to about 40% of their siblings. And about a quarter had a severe or life-threatening chronic condition, as compared to probably only 5% of their siblings. And they define these severe or life-threatening conditions as a history of an MI, a stroke, blindness, diabetes, or a subsequent malignancy. So I want to talk about, spend a little bit of time talking about subsequent malignancies. So what is a subsequent malignancy? So we mean this as a new primary cancer that occurs after an initial cancer diagnosis. So some people refer to these as secondary malignancies. The preferred term these days seems to be subsequent. So this is a new cancer that's developed that's not related to the initial cancer that we transplanted the patient for. And so this is data from the Center for International Blood and Marrow Transplant Research, showing the cumulative incidence of subsequent malignancies after transplant. And it's actually quite striking. You see here that this curve just keeps going up. And we start off at about double the risk as compared to the general population in the 0 to 5 year range. And that goes up to almost a 5-fold increase in risk out at the 10 to 15 year mark. So these are significant risks. And who knows when that curve is going to level off on the right side there. We're already at 20 to 25 years post-transplant, and we still see that number going up. We know that patients are at risk of a number of different types of cancers after transplant, but the biggest ones seem to be those of the oropharynx and esophagus. Many of these are related to graft versus host disease, which we know, especially the chronic form, when it affects the mouth, can lead to an increased risk of malignancy in the mouth and in the esophagus. And skin is also a big one, including melanoma. Thyroid, liver, CNS, and bone and connective tissue make up many of them. The number on the right side here, I should mention, is what's called an SIR, or standardized incidence ratio. So it's basically the number of observed to expected cases of this type of cancer. And the expected number comes from the denominator, the expected number comes from data from the general population. So we're looking at numbers that are, 5 to almost 30 times higher than the general population. And so what we aim to do in the long-term follow-up clinic is what is really an individualized risk assessment for subsequent malignancy. So we have a number of inputs into the risk assessment for each patient. And so most of these inputs are really data-driven. So what that means is we need to know the particular transplant details, the particular patient characteristics that are associated with risk of subsequent malignancy. So this is really like what I would like to say personalized medicine, but it's not kind of like the sexy personalized medicine like CAR T cells or gene editing, but it is really looking at a specific patient and all of their risk factors and putting them together and coming up with an individualized counseling and screening plan. So this is quite different than what we do in the regular BMT clinic, where we're very focused on what are the blood counts? Is there graft versus host disease? What are we doing with their prednisone and cyclosporin today? This is a totally different approach, and this is why specific survivorship clinics are so important, so that we can have the time and space to do these kinds of assessments. So I'm going to tell you about a couple of patients that we've been following in the LTFU that have developed subsequent malignancies in their short follow-up time with us. So Miss 1, so these are Miss 1 and Miss 2, both around 50 years old. Miss 1 is around 3 years post our typical fludarabine busulfan 4-grade TBI for CMML in remission. She had mild chronic graft versus host disease that's resolved, and she has a big smoking history, currently still smoking about a pack per day, and a family history with a mom having breast cancer in her 40s. And then Miss 2, 40 years post-transplant with cyclophosphamide and a single fraction of total body irradiation for AML, and then was lost to follow-up at around 12 years post-transplant when we were able to see her again in the clinic, as she was referred from her family physician. And she was, when we first saw her, physically well, unfortunately many psychosocial challenges. So we know that there are some very well-known risk factors for subsequent malignancies after transplant. So we know that total body irradiation as part of conditioning is certainly one of them. We know that patients who have had localized radiation pre or post-transplant, so think about those patients with mediastinal masses who are getting, say, mediastinal radiation before transplant, sometimes after transplant. Chronic graft versus host disease is a well-known risk factor for subsequent malignancy, younger age at transplant, and then certain habits, alcohol and tobacco use. When it comes to total body irradiation specifically, we also know that age is a really important modifier of risk. And so we know that those who receive TBI when they are younger have a much higher risk of subsequent malignancy. It seems to be that when you expose growing tissues to total body radiation, that there's that higher risk of malignancy. So when you give TBI to someone who's under the age of 10, you can see here that there is a massive increased risk of subsequent malignancy, 55 times the risk of the general population. And when you get out to age 40 plus, the TBI doesn't seem to have a major risk associated with it in addition to the chemotherapy that you're giving. The other thing we know about radiation is that fractionation is important. So when you give a single dose of total body radiation, their risk is higher of developing a subsequent malignancy. And the reason for this is that it's the theory here is that when you fractionate radiation like we do with our patients, as you all know, on 57, we send our patients down for 2 doses of the radiation. So we split that 4 gray into 2. When you give patients a break, there's actually some tissue repair or DNA repair that seems to happen in between the fractions. And that seems to perhaps reduce the risk of subsequent malignancies in the long term. So what we see is that patients who received a single dose of TBI will have a lower risk of subsequent malignancy as compared to patients who had fractionated TBI. So again, these are kind of important. These are important factors that we need to look at when we're trying to counsel patients about cancer screening and what their risk of subsequent malignancies might be. There are novel risk factors for subsequent malignancy that we need to look at. Most of the studies of total body irradiation really have focused on high doses that have traditionally been used with allotransplant back in the 90s and early 2000s. Most of the studies are looking at doses ranging from 6 gray all the way out to 14 gray. Those are huge doses of total body irradiation. As you know, there is a movement towards using lower doses of TBI with transplant. So in Calgary, we've been just using 4 gray for quite a while. And we don't know whether that's associated with the same risk of second malignancy or subsequent malignancy as patients who have received higher doses. The second thing is metabolic syndrome. So we'll talk a little bit about that. So as I kind of mentioned, we've been using low-dose TBI in Calgary for actually quite a while, dating back to when Dr. Russell was running the program, for those of you that were around at that time. And so we've been doing this for longer than many other centers in terms of low-dose radiation. And so what Dr. Russell showed back in around 2010 or just before that is when we added the low-dose TBI at 4 gray or 400 centigrade to our myeloablative fludarabine busulfan that you're all very familiar with, patients with AML had a better survival. So it seems like this low dose of TBI is actually quite important for preventing relapse after transplant. And some centers have followed suit, and so there's a bunch of other centers using low dose TBI now. And there's also a number of new protocols coming out. For example, our sickle cell protocol that we use for allo, where we're using something like 2 gray of total body radiation. And when we start to do haplotransplants for sickle cell, we'll be using about 4 gray as well. So there's quite a bit more use of low-dose TBI these days. And so the question is, does the low-dose TBI increase your risk of having a subsequent malignancy as compared to just the chemotherapy alone? And so this is the question that we have set out to answer. And so it's a project that Lena took on when she was in the long-term follow-up clinic with us, and something that we're still working on and getting close to publishing, hopefully in the next couple of months. And I can show you a little bit about a little bit of our data. So what we did was we looked back to 1999. We have 674 one-year survivors of allotransplant between 99 and 2014. 400 or so of them received the TBI, and about 250 didn't receive TBI. And so what we really wanted to do was compare the risk of subsequent malignancy between those two groups. And we also just wanted to know in Alberta, how many of our patients are getting subsequent malignancies. So this was an important project for us, just to be able to have a look at our local data and be able to counsel patients, because sometimes this does come up in terms of patients asking questions, rightfully so, about what the long-term risks of transplant are. So the average age, like I kind of mentioned before, our average age at transplant is fairly young. It's 47 for this group of patients, for this whole cohort of patients. We followed the patients for a median of about 9 years. And what we found is 49 of those 600 some patients developed 56 different subsequent malignancies at an average of about 6 years post-transplant. We didn't include post-transplant lymphoproliferative disorder, which tends to happen quite early in the first few months after transplant. And we didn't include non-melanoma skin cancers, things like basal cell and squamous cell carcinoma that are very, very common. Important, but not really the focus of our question here. So what we found is a cumulative incidence of second malignancy at 15 years post-transplant was 12.5%. So essentially 1 in 8 of our patients are getting a subsequent malignancy out at 15 years after transplant. And when we compare that to the general population, what we did was we pulled all of the Alberta specific rates of cancer and matched for age, sex, and sex. And we found that our patients have about a twofold risk as compared to the general population when we're out at 15 years. When we compared those who received TBI to those who didn't, we actually didn't find a difference. So it seems like probably just the myeloablative conditioning contributes to this increased risk of subsequent malignancy. It might be that our patients are adults and the TBI seems to be less damaging at these doses of 4-gray. But what we did find is, as we expected, patients who get chronic graft versus host disease did have a higher risk of getting subsequent malignancies. So again, something that we need to keep in mind when we're assessing these patients in long-term follow-up is, adding that chronic graft versus host disease piece into their risk profile when we're thinking about risks of subsequent malignancies and screening. We also found that older age at transplant is associated with subsequent malignancy numerically. And this is an important and kind of interesting point. And so the reason why I've told you on a previous slide that younger patients have a higher risk of a subsequent malignancy, but really older people are going to get malignancies in any case, even regardless of having had a transplant. And so when you just look at numbers numerically only, the older patients have a higher risk of getting a cancer. But when we look at comparisons to the general population, we found that patients over 50 have about a 1.5-fold risk of increase as compared to the general population, but our patients who are younger than 50 had an over 2-fold risk of a subsequent malignancy. So even though numerically the cancers are less in the younger patients, their risk as compared to their age-matched peers is higher. So it's an important point. When we looked at sites of second malignancies, we found a lot of them were in the GI tract. So like I mentioned, esophageal, gastric cancers. We did see a couple colon cancers, gynecological and genitourinary malignancies, lung, skin. So we really saw the gamut here of sites of tumors, including 4 breast cancers and 6 prostate cancers. So I think the implications here are that if you look at that curve, we should expect more. And this curve doesn't level off. We followed patients for an average of about 9 years in this study, and that's relatively short. And that curve I showed you from the CIBMTR data, that curve just keeps increasing right out to 20+ years post-transplant. And so it's really important that we are being vigilant with our patients, counseling them about their risk factors and having them do appropriate screening. So if we go back to those 2 patients and think about their risk profile, Miss 1, what we're worried about here is the family history and the smoking in terms of her risk profile. The TBI, knowing what we know now, is a little bit less of a concern for a 50-year-old. Getting 4-gray of TBI. The time post-transplant is she's not very far post-transplant. We see that risk goes up with time, but the family history and smoking are concerns. For Miss 2, it's the opposite. So we know that single fraction, remember, single fraction, somewhat higher dose of total body irradiation here at 7.5 gray in a single fraction and the time post-transplant. So this patient is about 40 years post-transplant, received TBI at a young age, and so we're really concerned about the transplant-specific risk factors here. So for Miss 1, it was the screening mammogram at age 50. After joining the clinic, she had a 1.2 centimeter left breast mass that was an invasive ductal carcinoma, and luckily picked up at an early stage with no nodes, no metastases, and has been treated for this. Unfortunately for Miss 2, it was a worse story. She developed abdominal fullness, nausea, and a 10-pound weight loss, and was found to have a pancreatic head mass and a pancreatic adenocarcinoma. So it does illustrate that we're not going to be able to prevent every type of cancer. There's really no effective screening strategy for pancreatic cancer, but we can do what we can do to reduce risks as much as possible. I'll just touch on metabolic syndrome. And so we know in the general population that there is a reasonable degree of evidence that links the metabolic syndrome with various types of cancer. So it stands to reason that that might be the case for patients who have had an allotransplant. And we know that allotransplant is associated with accelerated development of risk factors for cardiovascular disease, as is autologous transplant to a slightly lesser extent. But what we see here is the 10-year cumulative incidence of various cardiovascular risk factors in the red bars as compared to the age matched controls in the population who have not had a transplant. So we see more hypertension, we see more diabetes, we see more high cholesterol, and we see more combinations of risk factors as compared to the general population. So certainly the treatment that we give patients does affect their metabolics and makes it much easier for them to acquire these risk factors. And the acquisition of these cardiovascular risk factors can be kind of conceptualized more globally as the metabolic syndrome, which consists of some combination of trunk obesity, high triglycerides, low HDL cholesterol, hypertension, and essentially diabetes. And we know that this is a toxic condition. There's so far only one study looking at it after transplant. This is from Europe. And they presented this at ASH a couple of years ago, and we're waiting for them to write their paper. But they found that the prevalence of metabolic syndrome was about 30% after both allo and auto transplant, which is about double the prevalence of the general population. And they found that metabolic syndrome, somewhat not surprisingly, is associated with an increased risk of cardiovascular events in these patients, and interestingly, a higher odds of second malignancy. So it seems like it's not just the cardiovascular risk factors, and putting patients at risk for heart disease and strokes. It's also putting them at higher risk of subsequent malignancy. So again, these risk factors play into our assessment in the long-term follow-up clinic. And so what I've learned from these kind of recent studies is that in survivorship care, we need to stay vigilant. So as therapies change, as practice patterns change, there will be changing risk profiles for various late effects, not just for subsequent malignancies. So here are some new things we're doing on the board. What's going to happen to patients 10 years after CAR T cells? What's going to happen to patients 10 years after their BiTE therapy? Survivorship is, it's an old area, but it's also a new and evolving area. We need to continue to study what happens to patients late after the therapies that we provide, so that we can best take care of our patients late after transplant to protect them after all the therapy they've gone through. So I'll tell you just a little bit here about our adult long-term follow-up clinic in Calgary. We do have a pediatric counterpart, and in general in pediatrics, they've been always 2 steps ahead with respect to survivorship clinics and research. And so we now have an opportunity to try and catch up with the children's programs all over the world that have been doing this for much longer than us. We see patients who are more than 2 years after transplant without relapse or without graft versus host disease that needs to be treated. We started back in late 2018, and we're at the Holy Cross. we've seen now, as of January, when we tabulated the numbers recently, we've seen 233 patients, and we've done 439 patient visits in that time. And these patients have all come from the BMT clinic at the Tom Baker. So we've tried to offload the BMT clinic, which was getting quite crowded. And the major benefit that comes from this is the Holy Cross is not nearly as busy. We're able to book patients for longer visits and spend a little bit more time with them talking about all of the different potential late complications and how to keep them healthy. And what we want to do in the clinic, what we're really working towards still is a multidisciplinary model of care where we're really hopefully using all of the providers in the clinic to their full capability. And so the RN in the clinic plays a big role, does a detailed history and review of systems. And the RN in the clinic has always done counseling, so exercise, cancer screening, vaccination, linking patients with mental health resources, smoking cessation resources, and really connecting to other resources in the community for survivors that we have been collecting over the last couple of years. We're starting to see some patients come back for their second visits, and we're really trying to focus on, in terms of the cancer screening piece, make sure that patients are doing their appropriate cancer screening. And this data is a little bit old, haven't had a chance to update it yet, but this was, I think last year we had 53 patients who had returned for a second visit. You can see that about half of them were not doing their cancer screening appropriately, i.e. they were basically missing their cancer screening. Their things like mammography, pap smears, colon cancer screening. And you know, we were able to get kind of maybe 2/3 of those patients up to date when they were at their follow-up visit. And there's still about a third who are not up to date. And so we still have to keep working with patients, but hopefully we're making a difference in terms of having patients on the appropriate screening programs. After what I've told you about the metabolic syndrome and vascular disease, there's an obvious role for a dietitian in the clinic. And so we've had Caitlin and now Grace who do counseling around a heart healthy diet, calcium and vitamin D intake for bone health, diets for high triglycerides, for diabetes, and then patients seem to come with a lot of diet fads and falsehoods, which they're spending some time debunking. And this is really important because we know that lifestyle factors do modify the risk of cardiovascular events after transplant. This is a study from a couple of years ago that showed that if you had 2 or more of these adverse lifestyle factors, physical activity, smoking, low fruit and vegetable intake, your risk of having a cardiovascular event after transplant was 3-fold higher. Makes sense. It's not earth-shattering, but also points out, you know, that these are all modifiable factors, and if we spend the time talking to patients about them and counseling, we might be able to achieve some change. This is a little bit of an update that Nikki Blosser, who's our pharmacist in the long-term follow-up clinic, presented at a pharmacy oncology conference last year. So here are the comorbidities in I think the first 150 or 160, sorry, about 180 patients that we saw. You see here that obesity is a problem, patients having mental illness after transplant, chronic lung disease, bone fractures, diabetes, liver diseases, some patients still smoking, chronic kidney disease, cardiomyopathy. So this is not a super healthy group of patients. And so it's important that we talk about managing all of these comorbidities. And sometimes we're the quarterback between multiple specialists and the family doctor. So if you look at these severe diseases, vascular events, diabetes, subsequent malignancy, or chronic organ failure, 40% of our patients have one of those. So, you know, it really points to the fact that the risks after transplant are real. Patients also have symptoms that they report, and we do collect self-reported symptoms, and dry eyes are a really common problem that we're talking about in the clinic. Chronic fatigue and memory and concentration problems in about a third, and dry mouth as well. We have a pharmacist, as I've mentioned, in the clinic, and some of the roles that they play are telling us how much anthracycline exposure patients have had with all of their pre-transplant treatment. So anthracyclines, as you know, are cardiotoxic drugs. They're, you know, on the ward, probably the most common one that you guys see is idarubicin with our 7+3 induction for AML, or maybe doxorubicin for CHOP. And so they do cause cardiac disease in a dose-dependent fashion. So it's important for us to know in long-term follow-up how much exactly the patient has received, because it will affect our approach to their screening. We do calculate a Framingham risk, which is a risk of, which is a 10-year risk of having an arterial event, so a heart attack or a stroke. It informs us a little bit about patients' risk factors and does help us with counseling, although we think that the Framingham probably underestimates risks for patients who have had a stem cell transplant. It is generally made for patients who have in the general population. Our pharmacists will review vaccines to make sure the patients have completed their vaccine series, and they're reviewing supplements the patients are taking in conjunction with dietitians. Here's the first, I think, 100-some patients that we saw, and you can see here on the right that we've got a good population of patients who have received a high dose of anthracyclines pre-transplant. So that's more than 300 milligram per meter squared. So those patients are going to be at higher risk of left ventricular dysfunction or heart failure. So you can see here that, that really the dose-dependent problem with anthracyclines, as you get up into that 300 milligram per meter squared range, the chances or the probability of developing left ventricular dysfunction and heart failure increases. So those are patients that we may want to screen them more aggressively for left ventricular dysfunction with physical exam, with echocardiograms, or even in cases where we want to be really careful, cardiac MRI. And those are patients where we also want to really manage their cardiovascular risk factors well too, because it's not just the anthracycline by itself, it's also the cardiovascular risk factors. So you can see here that patients who have had anthracyclines plus other cardiovascular risk factors like high blood pressure or diabetes, their risk of having a cardiac event like heart failure or a heart attack is quite high. That's this top curve here on the right. Whereas the patients who have had the same amount of anthracycline but who don't have vascular risk factors have a much lower chance of having a cardiac event. So it really points to the fact that even though we can't change how much anthracycline someone has received in the past, we can reduce their risk of having cardiac events by detecting and managing their cardiovascular risk factors. So I'll just tell you briefly here, just to give you an example of how we do an assessment in the clinic and some of the things that we touch on. So this is a typical visit. This is a 39-year-old lady who is about 10 years post-transplant who was referred into the clinic. Quite heavily treated. She had Hodgkin's lymphoma and had 4 cycles of ABVD, so an anthracycline-containing regimen for 6 cycles. Unfortunately, she relapsed and she had DICEP, which you are all very familiar with on the ward, and then had a melphalan-conditioned auto-transplant. And then post-auto-transplant still had a mediastinal mass and so had some mediastinal radiation. And then unfortunately relapsed and went on to get GDP for 3 cycles and then had an allo with our typical fludarabine, busulfan, and ATG protocol. And so when we calculate her cumulative anthracycline exposure, it's 300 milligram per meter squared, so certainly on the high side. The post-transplant course was complicated by shingles, post-transplant lymphoproliferative disorder, and chronic graft versus host disease of the mouth. So here are the issues that we kind of dug out after assessing the patient in detail. She didn't have a family doctor, so that was the first step. We got to get her connected to someone who we can coordinate with in terms of taking care of this patient going forward. So we got her a list. When we examined her vaccines, some vaccines got left behind. She hadn't finished her live vaccine, so her MMR, as well as a pneumococcal vaccine. Particularly the pneumococcal vaccine was important because she was left with some chronic lung disease probably related to graft versus host disease, thus putting her at risk of pneumococcal disease, as well as her IgG level was low. And so again, a late complication of transplant, putting her at higher risk of invasive pneumococcal infections. And so it was quite important that we got her to public health to get a pneumococcal booster. She did have vaginal dryness and dyspareunia, and lo and behold, she's menopausal. Not surprisingly, after all of the chemotherapy she's received, she has premature menopause, and unfortunately had not been on hormone replacement therapy. And so we sent her to gynecology to have that talked about and hopefully started. She had a low bone mass at 1 year post-transplant on her bone mineral density, and now she's several more years of not having estrogen, and so she needs a repeat bone mineral density, and we need to counsel her about a bone healthy lifestyle. She may need bone building drugs once we see that bone density. When we look at her cardiovascular risk, she's got high risk pre-transplant therapy. She's had mediastinal radiation, she's had anthracyclines, and then she's been now menopausal prematurely for almost 10 years. And so these all put her at risk. We're going to look at her blood pressure in the clinic, her cholesterol, her blood sugar, and do a history and physical and counsel her about how to live a heart healthy lifestyle. She screened positive for depression and anxiety, and we were connecting her with resources in the community. And when it came to subsequent malignancy screening, she had not started mammography and had not had a PAP for 5 years. And so this is a young lady, and mammography doesn't really come to the top of mind for most healthcare providers who would see her, but given that she had that mediastinal radiation, that's typically quite a high dose of radiation to the chest, and so there is a significant risk of breast cancer in the years after transplant, and we need to be screening early. And so I'd like to thank everyone that's worked with me in the long-term follow-up. We've had, unfortunately, some people come and go, but here are all of the people that have contributed and continue to contribute to the clinic. And thank you very much.
Thank you, Dr. Jamani, very much for that important presentation and the information on a very important part of our patient's journey and the care that we provide. Appreciate that. So we do have time for questions. I believe your microphones have been reactivated. So feel free to ask away or type in the chat and I can watch that as well. Krista,
I guess I'll start.
Yeah.
Sure. Can you guys hear me?
Yeah.
Thanks, Kareem, for the talk. That was really great. Understanding that ACE is a fairly new program with all things considering, have you seen many patients having utilized that ACE program and maybe some of the, positive or whatever effects that you've noticed of that?
Yeah, absolutely. That's a really good point, Krista. So yes, we are routinely recommending ACE to like most of our patients, and that's based on the first few patients that we sent there. They've had a great experience. They're able to get even some, I think they do it in small group sessions, so they're able to get some individualized counseling. So for those of you who don't know, ACE is the Alberta Cancer Exercise Program. So it's an outpatient program for any patients who have or have been treated for cancer in the past. And despite COVID, they've gone virtual and they're still doing workouts with patients over Zoom. And we definitely are recommending this to a lot of patients, especially the ones who are relatively new to exercise, because they need that counseling and that support, I think, when they're getting started. So it's a hugely important resource.
As a quick follow-up, Kareem, too, if ACE wasn't in place, do you think we would have the ability to advocate for a program that would assist our survivors in accessing exercise long-term?
Yeah, so we have some limited resources. So there is a rehab program at the Holy Cross, and they do have an ability to see patients. So we have occasionally sent patients there to get kind of a consult and some recommendations for exercise, and they do a nice job educating patients and teaching them how to do some exercise. They don't have a huge capacity though, unfortunately. I know that one of the physiatrists in that program, George Francis, was working at some point on an online type program for patients who have had stem cell transplant. And so, yes, if we didn't have ACE, you know, I think in either case, rounding back with him to see where that's at, because it's hard to tell patients to, it's hard to just tell patients like, go exercise, you'll be okay. You know, I mean, a lot of people haven't had that experience, and you want to make sure that they're doing things the right way and they're not going to hurt themselves. So you're right, we need to have resources for that.
I do have one, and I guess maybe, oh, okay, it's just a thank you so much for the fantastic presentation. You said you did just such a great job of explaining it the first time. So
thanks, Irene and Kelsey.
My question is, so are you're the primary physician running this clinic, and then do the physicians rotate through it, and of course it's supported by multidisciplinary, but do you see how it's going to be run moving forward?
Yeah, so I'm lucky. So there's 3 of us who rotate through the clinic. So there's Baljeet Randhawa, who some of you probably know, a nurse practitioner in the BMT program. And she's taken an interest in survivorship and has done a really good job and is now kind of an expert in survivorship. And so she runs the clinic. And then Dr. Daly likes to do some of the clinics too. So so the 3 of us rotate, but we are growing, and we may need to add someone else. But for now, the 3 of us are managing.
Exciting to hear that's growing so much, though. Awesome. Well, thanks again. Oh, are you taking on cancer screening, tests, labs, etc., or directing people back to their GP?
Yeah, that's a really good question, Melissa. So we're mostly directing people back to their GP. So in order to try to not be overwhelmed as a clinic in terms of following up results, we're trying to mainly act as a consult service. So what we do is we do a full consult with all the details of prior treatments, and then we write an impression, and then we give recommendations to the family physician. So that's why it's important that we try and connect patients. And we find that the GPs know better than us how to order all of these nuanced things, how to get patients to a colonoscopy quickly, or how to do a fit test. Those are things that they're really good at. So I think they generally appreciate if we leave, you know, we give them some advice, and they can also continue to be involved. And then Lena is asking, how does our LTFU clinic compare to other survivorship clinics you have been through or know of? Is there other things you wish we had more capacity for? Yeah, so our survivorship clinic is actually relatively unique. So there are only, as far as I know, only 2 other programs. So Vancouver has a long-standing survivorship clinic where they do similar work to us. Toronto also has one where they do maybe slightly more limited assessments than us, and those are the programs in Canada. In the US, as you can imagine, at the big cancer centers, there's a lot of resources. They have, so in Seattle, their survivorship clinic is, you know, made up of like 4 people, 4 providers in the clinic at the same time, just for one clinic. So their capacity is massive. If we could have that, I would love to start seeing all of the patients who have even had an auto transplant. Right now, those patients are in kind of a hematology long-term follow-up clinic, and I know the nurse practitioner, Rebecca, who's working in that clinic, is also really learning to counsel these patients as well. But I wish we could incorporate more of those patients, even patients who have been through extensive treatment without stem cell transplant, it would be nice to be able to see those patients. And then Pam, are most of the patients pretty receptive and willing to be part of the LTFU clinic, or do a lot of patients drop off the map post-transplant long-term? So it's a well-recognized problem, and it tends to be younger people and men. This was actually just published last year. There was a survivorship program in the States that kind of looked at how many patients dropped off. And it is a significant minority, something like 15% or so will drop off over time, and they tend to be younger men. They disappear off the face of the earth. They feel, you know, they're doing great and they're invincible. The interesting thing is that oftentimes they come back when they're a little bit older, is kind of anecdotally what I've heard. The patients that we've seen in our clinic, we have lost some. I think it's about 10% last I looked that we saw have dropped off. And I think they've probably taken that opportunity after switching clinics to maybe have some freedom. So we can you know, I don't think it's super onerous. We only see patients really once a year, some more complex patients maybe every 6 months. But yeah, there'll always be some who are not, you know, that receptive, and hopefully they're connected with a GP and may come back in the future.
Great. Well, thank you again, and thanks for taking your time away from your dogs and kids and piano lessons or whatever else you're doing back there.